Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, part 2 of the episode of Josh Farkas and I talking about the ESICM papers. We already did Andromeda Shock 2 in an episode, and today we're going to talk about EVERDAC and BICARICU-2. Now, I want to get Josh on more. I love these episodes, and you feel likewise. We'll try to push him on more frequently, talk about what's going on in critical care, recent papers, etc. So now the segment needs a name. And so you like EMCrit, you like POEMCrit. What would be better than either of those individually? Well, the two of them together would be kind of like a supra-critical. Well, then obviously the show segment, the show title will be HyperCRITical. Now, you don't want to be a hypocrite, but you definitely want to be a hypercrit. Two crits together, hypercrit. So HyperCRITical is what we're going to be talking today, and we will be talking about those two studies right before we roll in really quick, and then we will get right back to the show. Folks, really quick, I just want to mention the Awake and Aware conference we are hosting in Scottsdale, Arizona at the very beginning of March. This conference is going to be incredible. It is a retreat type atmosphere. We're going to be talking about joy. We're going to be talking about productivity. We're going to be talking about finding happiness in work and outside of work. We're going to be talking a little bit about meditation, a little bit about inner voice, all sorts of stuff you've heard about for years through the coaching I've done, but now I'm together with 3 of my friends, all professional coaches, to talk about this in a concentrated 4-day experience. If that sounds interesting, go to Awake Aware Conference, all one word, awakeawareconference.com. Check it out. Scottsdale in the winter is gorgeous, so you should totally come. If you are an EMCrit member, I have a discount code I will send to you either this evening or tomorrow morning in the newsletter. We'll do one specifically for EMCrit members, and we will put the discount code in there. But you should totally check this out ASAP if this sounds even remotely interesting, because tickets are almost sold out. So let's get back now to HyperCRITical with Josh Farkas. Okay, so let's do the easier one first, which for me is EVERDAC. So I have interviewed the lead author of EVERDAC, so I have some inside scoop here. But what's your take on this one, Josh?
It's funny because we always used to joke when A-line never saves someone's life. And here we have a trial supporting that. Now, of course, this is like so many trials where you're basically randomizing to forcing an intervention on every patient versus allowing the clinicians to exercise judgment. So I feel like it's a little bit of a straw man question where with the patients who really needed an A-line, I feel like the clinician's just going to put it in.
Are you speaking to the crossover or to the safety barriers?
More in terms of crossover.
Yeah, there was some crossover. It wasn't enormous, and it didn't really change on the intention to treat versus as treatment received. Look, I like A-lines. I guess that's the thing to go in. Once they're in, and we could get them in so quickly with ultrasound, it's just a delight. It's a delight for everyone. It's a delight for me. It's a delight for the nurses. It's a delight for the ICU. Everyone loves it. So I was definitely against this trial. And you're not supposed to do this, and I'm sure you're a better person than I am, and you read with perfect equipoise as you're reading the trial. But for me, I'm like, if it's going against how I want things to be, I'm certainly looking for flaws more than I might be. And then I at the end say, Scott, where's your cognitive bias here? And then I go back and I try to have a more fair-minded assessment. I'm finding it hard to pick this one apart because no one liked the primary outcome. Mortality obviously is not the one, because if you ask me, Scott, does it affect mortality? I'd say, hell no. There's no way this monitor is affecting mortality. But then all of their secondary outcomes were all the stuff you wanted. Organ failure, vasopressor duration, all of that stuff they have encompassed in the trial. And then I'm like, maybe it's fine if they're on 10 of norepi, but if they were on like 30 of norepi, that's a problem. But they didn't stop at 30. They stopped at the equivalent of 70 something or even 80, depending on the patient's weight of norepi. And it was still no difference. I'm having a hard time justifying the patient outcomes from A-lines. Do you think there is any patient outcomes from A-lines?
I think this highlights one of the challenges in critical care, which is when you think about a huge population of critically ill patients, they're probably like 90% of those patients, they're either going to do well or not do well, regardless of who's taking care of them, regardless of what we do, regardless of, you know, how much coffee we had that this morning or how much norepi we give, or they're either going to, their outcome is probably relatively fixed. And there's that 5 or 10% that are like sitting on the fence. where a really good resuscitation could improve them. So I think the problem in any one of these critical care trials is you're doing a trial on all of these patients, but really there are only like 10% swing voters in that trial. And so it's really, I think, challenging to isolate those.
Yeah, I think that's fair, but didn't answer the question. Do you think A-lines bring patient-important outcomes to your swing voter group?
I do think that there's a group of patients who absolutely benefit from having an A-line.
What would those
you know,
benefits be in the face
so
of EVERDAC? I'm asking not to challenge
yeah.
you. I'm asking,
No.
hoping you'll say something that will allow me to keep pushing A-lines being placed.
I think certainly for the super unstable patients where their blood pressure is incredibly labile and we're going to intubate them or put them on APRV or something, I think it's useful to have a pulse by pulse blood pressure for anyone who's like coding or pericoding. I think those patients really
Very
probably
fair.
benefit from an A-line. And I think if we are titrating pressors in doing like a vasopressor challenge or an epinephrine challenge, I think that's actually really helpful. So if I'm going to give someone, do an epi challenge and put someone on 4 mics of epi, like seeing that blood pressure cut right up really allows me some more clarity about what's going on. Whereas like just sitting there and cycling the blood pressure, it's like a little harder to tell what's going on.
I think people are not, and I know this, people don't know their monitors as well as they should. There's all sorts of features of monitors that we are totally underutilizing. But depending on your monitor, most of them have the option of not doing their full cycle of inflate up to 180 and then bring them all the way down and recheck 15 times. You can get real near A-line rapidity blood pressure measurements with monitor settings. Now, some of them there's a button. Some of them you actually have to go and program your monitors. But I think we're underutilizing non-invasive to its fullest extent. And I think for stuff like that, if you have them both on continuous cycle, where as soon as it gets a blood pressure, it immediately starts taking the next one, and the one where it really is zoning in on what the last blood pressure was as its parameters, yeah, you could see those challenges. But, and again, I'm saying this, I just love A-lines. I love A-lines, but I want to give them their due. I thought it was crazy how many of their patients had the ultra high norepi doses and really made their study more inarguable, because if those patients still didn't need an art line, and of course it's an aggregate data, so I'm saying that with the full knowledge that we didn't really know, like it could have been that the vast swath of patients it didn't matter, and on those patients on 70 of norepi it did, and the signal was just too small to really push the needle anywhere. But I don't know. What this trial did tell me is if it falls out at 3 a.m. and the nurse calls me, I could tell her, we're going to wait till the morning with no guilt whatsoever. Do you take that from this at least, Josh?
Honestly, I've been arguing the opposite of my personal preference. I don't love putting in A-lines. It's not like my favorite procedure. So I'm usually someone who like drags their feet a little bit. But at the same time, if someone else has put an A-line, I'm like, that is great. Personally, I would love it if every single emergency medicine patient just got an A-line. My only objection
now, man. After this trial.
If residents like doing procedures, we can still get them to put in A-lines. My only objection to A-lines is sometimes it diverts attention away from the patient in other aspects of care. That's my only objection. But yeah, absolutely. The truth of the matter is, like, yeah, if the A-line falls out, that's fine most of the time. And if alternatively, like if you're really struggling and the patient is incredibly basically restricted and you can't get it in, I think this allows us to argue a wider range of practices.
And the study author, Gregor, was quite clear. If you need a systolic or diastolic, at least at this current moment, he would still advocate an art line. So for your brain injury patients who you're doing systolic titrations on, A-lines will still have a predominance. Now, his next study is to specifically look at that question. More to come.
I've never seen an A-line infection.
No.
Ever.
No. I mean, it was hematomas was the major problem in EVERDAC, which I don't care about that much.
So in your career, you've also never seen
I've never seen a radial art line. I have seen a femoral art line, but never saw a radial art line infection.
So we're two physicians agreeing that we've never seen a radial A-line infection ever.
Yep.
I have to say, radial A-lines can be uncomfortable for sure. They can cause hematomas. I've also never seen like a real nerve injury from one. I have to say that among procedures, it's probably one of the safest procedures. And
totally benign.
Even if you're like a pretty inexperienced provider, I think it's hard to hurt someone with a radial A-line. So,
and that was my point is, look, I completely agreed with the author on the patient-important outcomes for the most part, but there's a pragmatic utility to art lines. And since they are low harm, and then he said the hematomas, but then my thought was, I don't care about the hematomas. I will still put art lines in when they have utility for myself or for the bedside nurse. And patients did not like getting the blood gases taken without the art lines. So if it's a patient who you believe in arterial blood gases for that particular patient, I think their benefit comes then of not getting stuck repeatedly for what is a miserable, like art line sticks are miserable for patients.
Yeah.
And especially if you're doing multiple ones a day, put the art line in. All right, let's talk about BICARICU-2. This one's kind of tough. And so what is your initial gestalt of BICARICU-2?